The coronaviruses, which have evolved throughout in the past century, is that the vast majority of the human coronaviruses have all originated from bats. And most have gone through an intermediate host. In SARS, the intermediate host was the civet cat. In MERS, it's the camel. And in another one, the human coronaviruses, it's been thought to be the cow. So right now, the current thinking is that this virus did originate in the bat, and that an intermediate animal, at this stage, people are putting a lot of attention onto the spiny anteater, or the pangolin, as this may be, so the scaly anteater, because that may be the intermediate host. But at this stage, I think the jury is not totally convinced that this may be the true intermediate host. I think it's also important to remember that there are some viruses, some of the non-coronaviruses, which also have bats. And for instance, like Nipah virus went from bats into pigs and then into humans, and some of the rabies viruses. So you don't necessarily always need an intermediate host. The virus that in our studies we've found affects both the lower respiratory tract, and also it affects part of the eye called the conjunctiva. So it affects a wide variety of tissues within the respiratory tract, which accounts for most of the clinical symptoms. But we think it's also very important that, seeing how we've been able to demonstrate the virus can infect the conjunctiva, that this could be a route of transmission, which means that for prevention of infection is that eye shields should be worn by people in close contact with patients suspected to have COVID-19. Also, there's some increasing evidence that these coronaviruses do not only just affect the respiratory tract, but also the gastrointestinal tract. We found this during SARS, is that there was a big outbreak in Amoy Gardens. And with the new virus is that some of the studies which have been done in China have shown that they can actually find fragments of the virus in the patient's stool samples. So the route of transmission through the gastrointestinal tract is an area which many people are looking at now. No, it's not due because there's any new strains. What is happening is that now is that as there's more and more cases, and especially now with the increased screening, we're now picking up people at an earlier stage in the clinical disease. So that's why people have been complaining of things like loss of taste, loss of smell. Those have come about because of the earlier screening. Right now, there is no really good antiviral medication which is available for the population at large. There are trials of what things called the protease inhibitors, which are being done in a large number of countries, but this drug is not very widely available for a large proportion of the population. So what that means is that what people are left with in many parts of the world is just to either deal with dampening down the inflammation, or you're trying to prevent some of the replication. There's been a lot of interest about the use of hydroxychloroquine together with an antibiotic called azithromycin. And this is a very sensitive area about whether or not it really has some effect, because both of these drugs, some of the small studies seem to indicate that they had some effect, but they are associated with what's called cardiotoxicity, which means they can cause some arrhythmias in the heart. We have to balance out the potential dangers of these two medications versus the potential benefit. But for most of these studies, what really needs to be done is that these should be done in a controlled trial. That means that you have one group of patients with the same degree of symptoms. One group receives these two medications, the other group doesn't. And to actually see from a scientific point of view, in a controlled trial point of view, does one do any better? The problem right now is that much of this treatment is being led by anecdotal evidence. I think it's good, or I feel like it's a game changer. This is not the way in which medicine should be practiced. We should be based on science and on scientific method and on good trials rather than anecdotal evidence. The issue of reinfection depends on two things. The first is whether or not they have developed sufficient antibodies to the virus, and this is a very controversial area because we may have the antibodies, but they may not be necessarily protective. So even though traditionally we've said if someone's producing antibodies to a virus, they are therefore immune, we're so early into this outbreak that we don't know how much protection the patients having the antibodies are from future infections. There's recent unpublished data, it's for preprints, which seems to suggest that a third of patients who have had clinical COVID-19 have not developed antibodies. This is quite important because this means that are these patients still potentially infectious, or can they still potentially get the infection a second time? It's not ethical to do that, but what I think it indicates is that there are some patients who have very mild infection in which their body hasn't developed an immune reaction to this. The reason behind this is that the studies which we've found is that this virus, when it replicates, it may replicate only within some of the surface cells of the respiratory tract, and it may not be severe enough to actually allow the body to develop an immune reaction to it. So this is a very fast developing area. The other area which is now of very much interest is that people are now using the presence of these antibodies to see whether or not the patient has a virus. And there have been a number of tests, what have been called the finger prick tests, which have been used mainly in Northern Europe to try and detect people to see if they've got the virus. But just in the past few days, is that these tests have been found to be not very accurate, is that they're missing quite a few patients who've got active viral infection, but because they haven't developed the antibodies, the test will give a negative result. So I think it's important that from a management point of view and also from a screening point of view, is that it's best to go with the existing polymerase chain reaction PCR test rather than trying to look for these antibodies.